Shalom, everyone. I'm Samaya. Happy Shavuot. It is so good to see all of you. There's a little bit of reverb. I am Rabbi Bailey Romano. I am one of our rabbis and director of education here at Beth Hebrew Congregation. And I am so glad to welcome you to our panel on social and emotional well-being in the time of COVID. So I'd like to frame why we're here today and what holiday we're celebrating and why study is important and the connection to inclusion. So today is the holiday of Shavuot, which celebrates the receiving of Torah on Mount Sinai. We say Kabbalat Torah. And this holiday typically emphasizes study. You might have heard that there are folks who will study all night before the morning of Shavuot and then all day. Thank you for fixing the reverb. And so this holiday's tradition, especially, and it's a special emphasis on study, seemed like a good idea for a program focused on learning how to support the mental health and well-being of ourselves, our families, and our community. Moreover, you may not know this, but the giving of the Torah exemplifies inclusion. There's a quote from Rabbi Yochanan who said, "When God's voice came forth at Mount Sinai, it divided itself into 70 human languages, so that the whole world might understand it. All at Mount Sinai, young and old, women and children, and infants," and this is the important part, "according to their ability to understand, received Torah. Moses, too, understood only according to his capacity. As it is said, Moses spoke and God answered him with a voice that Moses could hear and understand." This emphasizes that Torah was not only received by everyone, but also that the divine consciousness understood how important it was and is for all to share in Torah, regardless of age or ability, and for that to be a part of our people's greater whole. I like to say this quote from the Torah, which is, "Lo b'shamayim hi." The Torah is not in the heavens alone, but it is in our hands and our hearts and our mouths. And so today, do we focus on the Torah of well-being? The rabbis taught that the highest goal is pikuach nefesh, saving a life. But the rabbis didn't understand that saving a life was only about your physical well-being. It was about your mental and emotional well-being as well. So today we come together to bring Torah into our hearts and minds and words and into our actions with this session on social and emotional well-being. We are especially proud of our community and our religious schools' continued devotion to inclusion. That's one of the reasons why I am here today. And we're very proud that two of our very own Beth El Religious School students are here as panelists. We'd like to welcome back Lizzy Mass and Hannah Kaye, both who attended Beth El's Religious School. And we are also so excited to have Randi and Terri here to teach us and learn with us this afternoon. So without further ado, I would like to lead us in Motzi, our blessing before we eat. Baruch atah Adonai Eloheinu melech haolam, hamotzi lechem min haaretz. Amen. Blessed are you, Adonai, our God, ruler of the universe, for giving us sustenance, bread, and food. Thank you.
Okay.
Oh, sorry, I just missed one.
You do mine.
There will be a 5 or 10 minute break while people get food, and then we'll resume the program. Hi, my name is Jean Holden. I am the chair of Bethel's Inclusion Committee. Our committee has 3 goals: improving building accessibility, raising public awareness about inclusion and acceptance, and ultimately welcoming all who come through our doors so they can participate as fully as they desire. I'm delighted to see you all here today and to welcome our special guests in person, Terri Mason and Randi Fortier, and participating virtually, Lizzy Mass and Kaye. They will each introduce themselves and briefly describe their backgrounds. Our program will explore mental health challenges in the time of COVID by life stages: children, teens, younger adults, and older adults. First, I'll ask some questions in a round-robin format. Then we'll take questions from the audience in the social hall. There are index cards on each table. If you would like to ask a question, please write it down, and a volunteer will pick it up and bring it to me. Also, if you get up for more coffee, please walk behind this table where our media technician, Michael Holden, is using cameras for Zoom and to live stream the program. Lastly, I'd like to thank our co-sponsors for this event, Bethel's Brotherhood, Women of Reformed Judaism, and the Religious School, and also a few individuals whose help was indispensable. Rabbi Romano, Brotherhood President Matt Mutterpearl, WRJ President Linda Shapiro, Bethel Board Member Judy Jankowski, and Inclusion Committee Member Dawn Kaye. Finally, my sincere thanks go to all the other volunteers who helped make this event possible. Now let's get started with the introductions. Terri, would you start?
Could we have Randi start?
Sure.
Hi everyone, my name is Randi Fortier and I am currently a high school counselor in Fairfax County Public Schools at Herndon High School. This is year 22 for me. Yay, yes, I know I made it. I started off as an elementary school teacher and then transitioned to school counseling about 17 years ago. So thank you so much for having me.
Good afternoon. I'm Terri Mason, elementary school counselor at Hunt Valley in Springfield. This is my 24th year there, and 40 plus years in education, starting out as a high school teacher. And I love being an elementary school counselor.
Well, I guess that would be one of our online.
Okay, I can go next. So, my name is Kaye. I'm really thrilled to be here today. We'll be here today with the quote marks, I guess, virtually. So I work with Iowa Primary Care with One Medical as a behavioral health specialist. I'm a licensed clinical social worker. Iowa Primary Care is a value-based Medicare-only primary care facility. 80% of my clients are over the age of 65, and the remainder have Medicare from being on disability. So I provide short-term counseling to patients and mental health literacy training to staff. My youngest patient was 23 and my oldest was 97, so I really ran the range, but my main focus is older adults. And I'm so excited to be here today. Thank you.
Okay, and last, Lizzy?
Good afternoon, everyone. Thank you so much for including me in this important conversation this afternoon. As Rabbi Romano mentioned, I grew up as part of the Bethel community. I went to Keshet at Bethel and was in Hebrew school all the way up through confirmation. So it feels like a real privilege to be back in the social hall where I had my bat mitzvah and to be addressing all of you this afternoon. My name is Lizzy Mass and I'm a licensed clinical social worker. I currently have a private practice that provides individual therapy to young adults and adults in Virginia, DC, and Florida. And I'm also employed at Catholic University's Counseling Center in DC, where I'm a therapist, a clinical supervisor, and the coordinator of the group therapy program. And prior to my time at Catholic, I worked at Emory University's Counseling Center in Atlanta, where I had a post-MSW fellowship, where I was doing individual therapy, group therapy, and crisis intervention work. So in total, I've worked in college counseling centers for about 7 years at this point. So I have a lot of expertise working with young adults, both undergraduate and graduate students, and I really love the work so much. I think it's really invigorating to work with this age group because identity development is so much a core of this age group. It's really exciting, especially to work with undergraduate students who might be away from home for the first time and really figuring out, who am I separate from my family? What are my values? What kind of mark do I want to leave on the world? And I think that has made the pandemic and the disruptions from the pandemic especially salient for this age group because their identity development has been disrupted. I have expertise working with clients around anxiety, stress, depression, life transition issues, identity development, trauma, relationship issues, family of origin concerns. And I'm eager to be a part of this conversation today, of course, to talk more about how the pandemic has impacted mental health for this age group. So thank you again for having me here.
That's great. Thank you all. Let's get started then with the round robin questions. Our first question, and since we're doing it by life stages, we'll go around starting with, if you will, elementary, high school, Lizzy, young adults, and then Hannah, since you've done the older. Our first question is, what are the signs of a significant mental health problem?
As a school counselor, we have mental health backgrounds, but we do not diagnose or really work in a clinical way as the other two that are with us on live stream do. So mostly what I tell parents is looking for changes in mood, changes in habits, those kinds of things, particularly over an extended period of time, are things to be concerned about.
And in the high school, it really runs the gamut. It's, I see it more as the symptoms of a cold. A student's grades are low. Their attendance is not what it once was. Those are the symptoms that you tend to see, and you then work with the student themselves to figure out what is impacting them or impeding their academic success. To define our role as school counselor, really we can't forget the word school, because ultimately that's the goal, for kids to be in class with instruction. But sometimes those impediments, the grades and the attendance, are just indicative of some trauma of some sort. So you really have to start asking those questions. What is happening? It's really about meeting with the students and seeing sometimes it's a matter that they're stuck.
And in the time of COVID?
Oh yes, definitely. Sometimes it's a matter of just school refusal altogether. Just coming into the building can be a struggle. Literally, in that young lady that I'm thinking of in my head recently qualified as a student under special education with an emotional disability. So these are the types of, we are trained to see what signs, and then we are also trained to dig a little deeper. And of course, in these cases, I'm collaborating with our school social workers. I'm collaborating with our school psychologists. And we work together as a team to support the students.
Okay. Lizzy?
Yeah, so when I think about the signs of a significant mental health problem, I think the most kind of broad way of looking at it is any distress that impairs some facet of a person's functioning. So whether that be, as Randi just said, like in the school with academic performance, whether that's at work with work performance, whether it's socially. When we think about the college population in particular, there are 4 signs that tend to be the earliest signs that there might be a significant mental health problem going on. The first, very similarly to what Randi just shared, is academic performance. So if their performance or attendance is dropping, that might be an early sign. Also social withdrawal, if we're seeing students who tended to be pretty engaged socially, involved in clubs, and suddenly they're spending a lot of time in their dorm and disconnecting, that can be a sign. If their substance use is increasing. And lastly, if their eating really changes, and this can go in either direction, whether there's heavy restriction going on, if there's a lot of appetite on the other end of the spectrum, if folks are really starting to overeat or binge eat. Those are some of the 4 earliest signs, I would say, with the college population that a significant mental health problem might be going on.
And if I could jump in on that, I would like to say that I have seen every single type of case that she just mentioned this week on repeat. So the eating disorders has become a major force to be reckoned with. And this goes for both boys and girls.
Hannah?
Yeah, so speaking clinically, the main things we look for are dysfunction and distress. So dysfunction, does your emotional health get in the way of you doing what you really want to do and what you were doing before? And then there's distress. So is mental health causing emotional or psychological pain? Specifically with older adults know a ton about themselves, which makes sense, right? Like you have over 65 years of experience in the topic of yourself. That's amazing. And yet at the same time, one thing that can make diagnosis or identifying problems different is that sometimes older adults, like not always, but sometimes are dealing with changes in mobility or energy levels, or they're also being diagnosed with a physical health condition at the same time. So that's one thing that can make it challenging to diagnose. But on the whole, like significant mental health problems are problems that make people feel apart or separated from others in some way and impact their ability to live a rich and meaningful life. It doesn't have to be the most extreme example of depression or anxiety, for example, to be a problem for that one person. So it's kind of up to everybody else to figure out what that definition is and when that time is to go seek help. One thing I see a lot in the senior population, these are people who have learned a lot of coping skills because they've lived through a lot of different times. A lot of patients come to see me saying they feel like they have no right to complain because they know that other people have it worse. That's something I hear more in older adults versus my younger adult clients. And I'm so grateful that they're able to overcome that hesitation to show up and come see me. So there's always somebody who may have it worse, but that doesn't change the fact that these problems are real problems.
Thank you, Hannah. Thank you all. Okay, second question. How do you suggest coping with Zoom fatigue and uncertainty about reemerging in society?
I think on my level, the kids take care of their own Zoom fatigue. I can't tell you how many times when we were all out and doing virtual learning, I would see kids turned upside down in their chairs or tipping over backwards or doing somersaults. So I think my age group kind of takes care of their own Zoom fatigue. And I think in terms of coming back, most of them were really excited to be back with their friends and back in the classroom. We did have a few kids who were hesitant and worried, but for the most part, on the elementary level, the kids were excited to come back.
I definitely think now that we have been in school in person for an entire year, the Zoom fatigue for at least our students is less. But the re-emerging portion is the part that they are struggling with. And they have forgotten, and well, to keep in mind, pre-COVID, they didn't know how to communicate then. And then add COVID, there was no, learning, socializing going on in the school day. So it's been very, one day at a time for each student. You have to handle each scenario differently, but I do agree that the majority of students were ready to come back and be in and amongst their peers and have that socialization. And I can say that the students that have that, when we talk about the majority of students, we're talking tier 1. When we talk about students who need a little bit more support, we're talking tier 2. But it's the tier 3 students who you're probably referring to clinical support at that time. It's much lower number, but we do have those students who are still very anxious about returning, even though we've been returned. So they make frequent visits to the clinical staff and work with us very closely.
Thank you.
Lizzy?
Yeah, so to start with the first part of the question around Zoom fatigue, I'm going to speak really to everyone in the room, not just for young adults or college students in particular, but I think that it's important to take control in any of the ways that you're able to, and I know that that will vary greatly depending on why it is that you're using Zoom, if it's for work, how much power you have to make decisions. But I would say this, that it's really important to think about kind of naturally when you have the most energy in your day. For me, it's the morning, and so for me, I might want to get all my Zoom meetings in the morning when I'm just naturally a little bit more energetic. And that might be different for different folks, and that's okay. There might also be folks who want to operate in a different way where they have a lot of energy in the morning and they might not want to be spending their time on Zoom, and they might want to pepper it throughout the day, making sure that there's breaks in the day. And if you're able to take those breaks, I highly recommend that you take a break that isn't on the screen, going for a walk, doing reading, whatever it is that you can do to really give your brain and your eyes that break from the screen. I also think about if there's alternatives to doing Zoom. Can you do a phone call instead? Can it be an outdoor meeting? Can you do Zoom but have your camera off? So be creative in thinking about how to make it work best for you given the level of power that you have to engage in decision making in your job. And then to the second question, Jean, the uncertainty about reemerging into society. First, I just want to say that it's really important, I think, to be compassionate with yourself if you are someone who's struggling with a transition. No one asked for this collective trauma to happen to us, and I really believe that the pandemic has been a collective trauma for the world. And I think it's important to think about that for those who are having some hesitation or reluctance to return to the way things were, that's extremely adaptive. Right? Early on in the pandemic, especially before vaccinations, it was really dangerous to be around other people and would have been dangerous to go back to the way things were before. So I think it's important to think about, to thank our bodies in a way a little bit. This was something very adaptive. It might get to the point where it's not as adaptive for us in the future once the threat has gone away, but we're still very much in the middle of the threat. When we think about traditional trauma treatment, one of the key factors is doing the treatment once the threat and the trauma is over. It's still happening, so it makes a lot of sense if folks are having difficulty readjusting. And I'll say, so be compassionate and gentle with yourself. All emotions are normal and valid, and it's important to validate that for yourself or for others in your life that might be struggling with the transition. I'll also say that it's important to go at a pace that you're comfortable with. It doesn't have to go, to 0 to 60 with total isolation to being back in person doing everything unmasked indoors. That you might consider looking at your values and using your values as a compass to prioritize what are the things that are most important to me that I really want to get back to normal with as much as I can, and to maybe take first steps there. But it also can be half measure steps that you take as well. If hanging out with your friends inside is the ultimate goal for you, you might start by doing that outside first, maybe with a mask on, maybe off, and eventually take little steps to the point where you're doing whatever the thing is that you most prioritize. And if that works well for you, then you might go on to the next thing on priority list. How are you? And I also want to say that I think we can get into a loop of comparing ourselves to other people a lot. I think that happens especially in young adulthood. And it's important to know that it's okay if you go at a different pace than other people. You have the right to self-determination. It is your body, and you get to choose what you do with it. And lastly, I think that a really big difference between now and the very beginning of the pandemic is that we have a lot more tools at our disposal. So if you're very worried, understandably, about contracting COVID-19 and having severe illness or hospitalization, wear the mask, get tested, get vaccinated, and boosted to help decrease the likelihood that that worst case scenario might happen.
Hannah?
Yeah, so basically, I definitely want to say for the first part, like Zoom fatigue is real, and especially for some of my older adults, depending on how much previous teleconferencing they've used, that honestly, more than age, was such a predictor of how well they adapted. People who, didn't even have an internet connection at home adapted so differently than people who use their computer and their laptop and may have already had Zoom meetings regularly for work. So the main advice I've given to my patients is to try to switch it up. So for example, prior to the pandemic, a lot of my patients would call friends and talk on the phone prior to COVID. And sometimes that felt more normal than Zooming did as the new normal. So phone calls can definitely be a great way to change it up. Outdoor activities, when it's seasonally appropriate, are a great way to kind of avoid the Zoom fatigue as well. One thing that I've recommended both to my patients and to other staff who themselves are having a Zoom meeting is to actually cover up your self-view on the upper left-hand corner of the screen. So I recommend you can either disable that feature in Zoom, or you can actually just do what I do, which is just take a sticky note and slap it over the picture of yourself. I think it makes us feel self-conscious to feel like we're on camera in addition to the natural, kind of differentness about Zoom, and it's another reminder of how weird this all is. And as for re-entry, kind of similar to what Liz said, the metaphor I and a lot of other professionals use is getting into a pool. So the weather is metaphorically starting to get better. We're opening the pool up, and some people are going to cannonball right in or jump off the diving board, and that's great for them, but how do most people get into the pool? Well, most people don't dive in. They get in a little bit at a time. So for example, when I was a kid, first I dip in my toe, then my foot, and then eventually I would get into the whole pool. So one thing that I use for patients with anxiety about doing certain things, I usually have them create an anxiety hierarchy, kind of similar to the priority list that was already mentioned. So writing down a list from 1 to 10 of low anxiety events or high anxiety provoking events when it comes to going back out in the world. So for example, for a lot of us, but maybe not all of us, going to like a concert or a packed football stadium might be harder or might feel harder to do than say like making a Trader Joe's run. So make that list, and then intentionally starting with lower anxiety-provoking activities can be a good strategy to reemerge slowly. At the same time, have compassion for yourself, but it might not make sense to wait until we feel 100% zero anxiety to go out to start taking small steps. Because some anxiety about going out in this post-COVID world may help keep us safe, right? Anxiety can be protective as well. For example, if anxiety helps you walk in the other direction, if you see somebody like violently coughing in the grocery store and they're not wearing a mask, like that's a good thing. So it can be helpful to remember, and this is something I talk with patients a lot. The goal is not zero anxiety. That's not very realistic, so don't feel like you have to get there. And in fact, you may have had anxiety about getting sick or germs before the pandemic. This is nothing new. Rather, the goal is kind of turning the volume down, not changing the channel. So making sure that the anxiety is lower or more manageable.
Okay, question 3. Teens are often more open about discussing mental health issues than their elders. How do we move this openness toward parents, grandparents, and other adults? And as part of that, what are some tips for helping individuals to work through difficulties about talking about mental health?
Since I work with the Little Friends, but one of the things I thought of when I read this question was, I'm a big reader and I love books. I listen to a lot of them now as opposed to actually physically reading them anymore, but I think getting a book, one of my favorites recently has been Brene Brown's Atlas of the Heart, where you can just talk about, it's a book about feelings and giving more language to different kinds of feelings. And I think the more we have language and the more it helps us to be able to talk about these kinds of things. So, getting a book and reading it together, I think is a great way to start some of those discussions.
Absolutely. When I first read this, I read it incorrectly, but now that I'm rereading it, teens are often more open about discussing mental health issues than their elders. I don't know if I agree with that. It's not easy. I work with a lot of students, and a lot of it comes down, and I know some of the future questions talk about cultural competencies, but it really does sometimes impact a student's ability to divulge. It's also, I see a lot of times teens do not want to be the burden. They are very concerned. They see that their parents are concerned in times of COVID and are maybe struggling. So if they themselves have an issue, they are not so willing to discuss it because they are afraid to bring pain or some sort of negativity to their parents. So I have to be honest, it does take coaxing with students, and I always attempt to give choice when it comes to having those discussions with parents. But I can also say that the majority of the time where there is an issue, what I find when it's a struggle is that it is the parent who is also not willing to acknowledge that it is a mental health issue. I see a lot of parents divert the conversation to a physical ailment, and will take their, son or daughter to a doctor, to rule it out, and it's difficult. But I think through, what you said, definitely having those conversations, and I think the fact that the schools, particularly, have focused on the social emotional learning, it has allowed us to open even the curriculum for conversation. So I think that has been helpful in the schools for us at minimum.
Thank you. Lizzy?
Sure. Forgive me if some of what I say is redundant. I lost sound for a little bit, so I wasn't able to hear what some of my colleagues were sharing. But I think that one of the things I think a lot about is that it can sometimes be helpful to have more displaced conversation about mental health topics for those who have some discomfort around it. So it might feel kind of threatening or scary to talk directly about yourself, but it might feel a lot easier to talk about characters in a book or a movie or a television show. So if you are part of a multi-generational family and some of the older folks in the family might struggle around talking about mental health, but the younger folks are very, very comfortable, a great place to start might be just having a conversation about these characters to kind of dip your toe in the water, kind of to use the same metaphor that Hannah shared earlier. I love that, Hannah. And another thing I think a lot about is really validating the discomfort. We don't live in a vacuum, and if someone has a lot of discomfort around talking about mental health, there's likely very good reasons that they do. You think about the different kind of systems that are acting upon them in this world, and maybe the implicit or explicit messages that they might have received around talking about mental health. So if we can make space to validate the discomfort and to flesh out their ambivalence a little bit about talking about it. What ways does it serve them? Does it not serve them to talk about it? And to do that using active listening and a really non-judgmental, curious stance. If you're able to have that conversation with someone and they feel safe talking to you, it might increase the likelihood that they will talk more about it with you or others in the future. I also think about modeling the kind of behavior that you'd like to see. So if you're very comfortable talking about mental health and you want others to talk about it, you can start off by talking a lot about it around folks and really thanking them. So holding space for you and talking about how it really impacts you and allows you to show up in an authentic way. And then I guess I kind of roped in the last piece there too, which is to reinforce positive behavior, so to speak. So if someone asks you how you're doing and you talk about how maybe you're not doing that well and you're struggling with some mental health issues and they do hold space for you and are supportive, thank them for doing that and let them know how heard and seen you feel by them and how you feel better knowing that they know this thing about you and feel more connected and sure of yourself. So those are just a few tips.
That's great. That's great.
Yeah, so I really love what you said, Lizzy. Like, I think talking about your own experiences can be like very powerful and destigmatizing as well. So I'm a numbers person, so I think one of the first things that we should do is, kind of on a global level, but also when talking with your family, distribute some statistics about how common of an issue it is. The very fact of mental illness is it makes us feel isolated and makes it feel like, somebody, it's just their own personal experience, and it's tough to realize other people are going through the same thing. But actually, an estimated 26% of adults suffer from a mental health problem in a given year. 1 in 5 people reported the pandemic significantly impacted their mental health, and that was like back in November 2020. There's been a lot of pandemics since then. I feel pretty safe in saying that that number has only increased. Our society is just now starting to change how we stigmatize mental health, but in fact, 1 in 3 adults will experience clinical anxiety or depression in their lifetime in the United States. To put that in perspective, that's 3 times greater than the population of left-handed people in the US, and it makes anxiety or depression more common in the United States than having blue eyes. Like, wow. I think getting the right set of numbers and explaining the statistics to people can help people feel less alone. And then to bring it specifically to older adults, a big part of my job is educating seniors about what therapy is and what it isn't, because therapy has changed enormously over some of their lifetimes. My oldest client at my job was 97, born only 2 years after Freud published The Ego and the Id, which was one of the founding documents to establish the entire field of psychotherapy. And we've come such a long way since then. I always joke about the lack of a couch in my office, and some of my older adult patients, they think that's real funny, right? But part of it is teaching them that therapy or counseling isn't the terrifying thing that they may have seen on movies like One Flew Over the Cuckoo's Nest, and showing them how it changed to try to destigmatize that. And as there have been more favorable depictions of therapy in the media, so the movie Good Will Hunting, Robin Williams played a therapist, that was a very positive portrayal. I feel optimistic that this is going to get better over time. If you are trying to bring up, concerns about mental health to a loved one because you want to help them, it's always better to start from a place of curiosity. So some of the, tips I've given my clients are saying things like, hey, I've noticed X, Y, Z. I wonder how that feels for you. I'm concerned. I believe you deserve to feel better. What are your thoughts about blah, blah, blah? Versus, I think you have X, Y, Z, which can almost feel more like an intervention or an interrogation. So really coming from a place of genuine compassionate, and curiosity, I think would be so wonderful.
Thank you. I think one of you mentioned equity and culture. So my next question is, are questions of equity and culture affecting the COVID-related mental health issues of different life stage groups?
I would say that I don't know that COVID is the reason. I think it's always existed. That unfortunately it is and has been, as several of the panelists have already mentioned, a lot of stigma about mental health. And so I don't think it's just around COVID.
I definitely see a discrepancy when it comes to different cultures accessing mental health, or the desire to. I know a lot of the Hispanic families that I work with in particular, their go-to is their faith. They go to the church and have those discussions, so it can be somewhat limiting. And I know the same, you know, we are Asian and Pacific Islander demographic is on the rise, and they as well are not as willing to share, divulge, and that more comes from shame. And it's definitely something, you know, and as a counselor, and I've heard both ladies say, it's definitely, I'm comfortable talking about it. So I think with me being comfortable talking about it, I'm able to parlay that conversation. And sometimes it takes, you know, bringing a parent in to widen their eyes. And that can be difficult too. It's a hard conversation to have, but it doesn't mean you don't have it. So it's, you know, you have to sort of you put yourself in their shoes, and bring them to your, you know, to the table and have those conversations with them. You know, sometimes they understand a little bit better because, and at the root of it for us is the student. No matter how the parent may feel about mental health or how to manage mental health, it really does come down to the well-being of a child.
Randy, you're getting to a follow-up question that I'll say, the follow-up for that was, how do you support and help students and for the others, clients or families, when there are cultural stigmas or reluctance to get help, whether through school services or other treatment? So let me throw that into the mix if you've got anything to add, if not.
Absolutely. And I can say personally too, I am very fortunate to work with our school social worker who came from the community after 20 years of being in the community. So she is very well connected. And both she and our school psychologists are well connected and run practices of their own. So are knowledgeable if it is an Asian or Pacific Islander family of therapists, counselors that exist for that particular demographic. That was the question?
Yeah.
Okay, yes, definitely. So I think it's just, you know, leaning on the resources that we have access to in the schools. That's definitely the step that I take.
And I guess I would say always, when whatever's going on with a child or a family, I approach with curiosity and ask a lot of questions and tell me more about how that works in your family. What does that look like in your family? And just ask a lot of questions and be open and curious.
Thank you. Lizzy?
Yeah, so I'll answer both parts of that question, Jean. The first around, are there equity issues? I would say unequivocally, yes. I had a colleague really early in the
If you want to say to her in the mic to hold on for a second.
Lizzy, hold for a moment. We've lost your feed for a moment. We're getting it back.
Maybe we are.
It's us. There we go. We're back.
We're back.
Okay, I'll start that again. Forgive me if I'm repeating myself. I had a colleague who shared a metaphor that I thought was really powerful around this issue, which is that in terms of the pandemic, we are all in the same ocean, but we're in different boats. And I thought that it captured it really beautiful. beautifully. And I think a lot about Maslow's hierarchy of needs in this kind of regarding this issue. And what I mean by that is that we can't really focus on our higher level needs, which might include some mental health and well-being needs, if we don't have our basic needs being met. Penn State University has a wonderful research center called CCMH, which is the Center for Collegiate Mental Health. And part of what they do is they provide some intake paperwork questions to most of the counseling centers, university counseling centers in the country. And one of the items that they added very, very soon after the pandemic started was, are you, as a college student seeking services at a university counseling center, coming for a presenting concern that relates to the COVID-19 pandemic? And about a third of students said yes, which comprises about 30,000 students. And of those students, about 8.5% said that they were presenting due to housing and food insecurity. And that's not a small number of students. And when we think about the college student population, I don't think that naturally we come to thinking about housing insecurity or food insecurity, but it exists in this population in droves. I also think about, March 2020, when students were, at their colleges, which might have been in a different community than where they live, and they were, ripped away from that community back into their family of origin home for most folks. And just that wasn't always a pleasant experience for people. They might be going back into an environment, it could be that was very supportive and loving and well-resourced, and it could have been meant going back into a home where there was abuse or substance abuse in the family, where there might not be access to the internet, which really got in the way of being able to do virtual learning or to attend virtual therapy with me or whoever their therapist was. I also think about, when we zoom out and think about young adults more broadly, thinking about equity issues around being even able to work from home. Are these people who were essential workers who had to put their health on the line and be exposed to COVID at work? Or were they folks who could comfortably work from home who had internet access? I think about benefits as well. Do employed folks have paid time off? They have sick leave. What happens if they get sick or a loved one gets sick? Are they able to take time off to care for that person or care for themselves? Or will they lose their job if that happens? I also think about access to childcare, for young adults, whether they have children themselves or have some kind of responsibility for another family member to provide childcare, and thinking a lot about young adults who had to juggle a full-time job with a little one kind of on the side, helping them do their virtual learning. And I also think about, when we think more traditionally about equity, I'm thinking about racial discrimination. And many of you may have seen the CDC release data in the last couple of months about mental health for high school students, which I know is not a population that I directly work with, but still captures the adolescent kind of into young adult stage of life. But it feels worth mentioning that they found astonishing numbers that over a third of high school students who were surveyed have experienced racial discrimination either before or during the pandemic. And not surprisingly, these numbers are the highest for Asian students, for Black students, and for students who identify as more than one race. So yes, I think that unequivocally there are equity issues, and then what do we do about it? I think, thinking about my work at Catholic University's Counseling Center, something that we did was look at the numbers in terms of utilization rates, and what we saw is that our BIPOC students were disproportionately underutilizing services at the counseling center. And so we thought about where might be safe spaces on campus where they spend a lot of time, where we could provide services that might take away some of the barriers for them coming to the counseling center. So we partnered with the CCE, which is the Center for Cultural Engagement, and started to have walk-in services with therapists in that center, so that if folks were afraid of coming to the counseling center, that a peer might see them there or judge them, or if just physically getting up to the counseling center felt like too much of a barrier, they could access the service right where they are. And then we could build a relationship with a student, and if they were really needing a higher level of care, they might build trust with us and then eventually feel comfortable coming for weekly therapy at the counseling center. Similar to what I shared earlier about folks who feel uncomfortable talking about mental health, If there are folks for cultural reasons who are having trouble accessing services because of stigma, we really want to create a space where we validate that discomfort, where we understand where it comes from, again, fleshing out the ambivalence, talking about the pros and cons, and really approaching it from a curious, non-judgmental perspective. And if we do that well, it might mean that maybe right at that moment, they're not in a stage of change that they're really ready to get help, but maybe when they are, if they get there, they'll think of us again and might circle back and ask us for resources at that point. I think so many of us have very good intentions and really want to help people get support, but I think it's really important, again, to honor folks' self-determination, that they get to choose if and when they're ready to get help, and to know what our limits are. That doesn't mean that we're bad people if we're not successful at the first try of getting someone to get help, and to be gentle with ourselves about that in that process. And then lastly, I think it's really important to encourage folks to seek support where they feel most comfortable. There might be a lot of stigma around coming to a mental health clinician or to a school counselor that might prevent them from doing that, but there might be other leaders in the community that feel more comfortable, like a primary care provider, like a religious leader, like an indigenous healer. And so if we can partner with those leaders and teach them and talk with them about what the resources are in the community, it'll increase the likelihood that when those folks go to talk to their leaders, that they might pursue mental health resources in the future, because if they really trust this person and they say, yes, this is a good resource, I encourage you to get it, they might feel much more comfortable doing that.
Jean,
Yes,
can you have Lizzy define BIPOC, because I'm not sure everyone knows what that is.
thank you,
I
Samantha.
almost,
Yeah.
I was
Lizzy,
thinking of
would you
myself.
please define BIPOD? What's that? BIPOC. BIPOC.
Absolutely. So Black, Indigenous, persons of color.
Did everybody hear that?
Black,
Oh, okay.
indigenous, person of color.
Thank you. Hannah?
Yeah, so first off, I would definitely say absolutely, like people with different resources experience like a different pandemic in a lot of ways. So for example, my patient who lived in like a large single family home with a backyard pool had a very different social distancing experience than my patient who like lived with 3 roommates in a cramped apartment, right? Like our economic resources actually absolutely dictate our experience with the pandemic. And since many minority groups in this country also experience structural oppression and systemic racism, low-income communities, communities of color, and people with disabilities often found themselves with fewer resources. Older adults specifically who are on a fixed income, especially if they were already retired, were less able to weather the supply chain issues and the price fluctuations that resulted and are still resulting from the pandemic. Like one example was like, you know, the toilet paper shortage of March 2020. I think we all have that burned into our memories. You know, my husband was able to go to 5 different grocery stores to find the one that still had toilet paper left. Some of the older adults did not feel comfortable or safe doing that, or didn't have the gas money to be able to do that, just one example. And some cultural groups or age groups definitely can have greater amounts of stigma or reluctance when it comes to accessing mental health services. I see it a lot in my population with older adults, although that's changing, like I mentioned before. I also am kind of lucky because I work in a doctor's office. I can automatically tie mental health to physical health because I'm there. So if you explain to someone like our body and our minds, like they're like this, they're not one over here, one over here. The 2 systems talk to each other. Your mental health can affect your physical health, especially chronic conditions like diabetes, hypertension, etc. That can help understand more and can help people of all different persuasions like really get more buy-in. And I also tend to provide support by using a couple different metaphors to explain and destigmatize mental health treatment. So for example, you can have the best car in the world. It can be like a super fancy luxury car, and it's still gonna need an oil change, right? Or other maintenance, or sometimes it might get into an accident. That doesn't mean it's a failure of a car. It can still be such a nice car, but you still gotta take care of it. And sometimes going to get some mental health help is just getting some maintenance, getting an oil change. And then the second piece about equity, I really love the idea of cultural competency. So I actually was so lucky to get to co-create and facilitate the DEI, so like diversity, equity, and inclusion training at IORA. That was a company of 400 people. And we focused a lot on this related idea called cultural humility, not humidity, although there's a lot of that which I'm sure is why I made that mistake. Cultural humility is this idea that we can't really become fully competent in another person's culture because there's two dimensions, right? One, what is that culture? And two, how does that individual person sitting in front of you relate to that aspect of their identity or culture? So just as an example, there's an old joke that if you ask 2 Jewish people in a room about Judaism, you'll get 3 different opinions, right? Or maybe 9 and 10, we've probably all heard that before. But that just goes to show that everybody relates to their culture or their identity differently. So what's most important is to respectfully ask people what their identity means to them and how they interface with that identity too. If a patient tells me they're a certain religion, for example, I'll ask them, what does that mean to them? Or how do they feel it's influenced how they see the problem that brought them into counseling? It feels a little bit awkward to ask, but so far the reactions have been almost universally positive. Kind of like what Lizzy was saying, I also firmly believe that everybody deserves to have a therapist that looks like them, prays like them, loves them like them, and speaks the same language as them. I think that's so important in such a huge destigmatizing piece of making sure everybody has equitable solutions. So I work hard at my agency because I only see people for 15 to 20 minute sessions up to 6 times. I'm very much a short-term counselor. So I work really hard to match people at their request to a therapist who meets any criteria. So that could be like being of a certain race, age, gender, sexuality, religion. And one great thing about telehealth is then you get to pick from anybody in the state to try to match them with that preference. Or for example, in the case of Lizzy, like licensed in 3 different states. So you could theoretically connect with a therapist who is really similar to you that you feel more comfortable opening up with, kind of like all around the country, which is really wonderful. And as a Jewish person working with just throwing a number off the top of my head, probably 97% of my clients identify as Christian in their initial intakes with me. If they say finding a Christian therapist is important to them, I will absolutely do that and honor those preferences. For those of you who are looking for counseling yourself or who know of people who are looking for counseling, one thing I love about the website Psychology Today is they let you search by pretty much almost all of those parameters, so what language they speak, religion, sexuality, gender, race, all that stuff. So that way you can find a therapist you feel really comfortable opening up to.
Thank you. Okay, the next question will start with Hannah and Lizzy, simply because it's more directed at their cohorts. Many women who did it all before COVID, working, parenting, and or being stay-at-home moms, have lost the opportunities that were available before the pandemic. Things have changed, sometimes, drastically with the kids home and going back to virtual and going back to school and going back to virtual. What would you say to these people? And then one of the questions I've been handed follows up on some of that. Hannah, would you like to start this time, since you've gone last each time?
Sure. Okay. So first off, I would say that their thoughts and feelings are completely 100% valid. And I would also say that this is a systemic problem due to lack of universal childcare and lots of other things that I'm not going to get too far into. So if it feels like there's no easy solution to your problem, that's because there is no easy solution. Women who are balancing and often, haphazardly juggling all these different demands of society. They're smart people. There isn't an easy solution. So it's okay if you haven't found one. So just kind of to try to have that self-compassion. Sometimes, I work a lot with patients who are grandparent caregivers or who are caregivers to, for example, a parent or a spouse. And then oftentimes if I sense self-judgment, I ask them, well, what would you tell about your best friend in the perspective, or somebody just like you who had a similar problem? Would you tell them, you just need to get up at 5 a.m. and get more done, how dare you? Or maybe would there be some more compassionate language, kind of being wow, you're doing a lot, and that's incredible and that's wonderful, and take some time for yourself. You know, and even for people like older adults who are still working, like society was designed around a 40-hour work week based on the idea of a married couple unit with the assumption that there would be a stay-at-home partner. And at the time when the 40-hour work week was created, that assumption was that that stay-at-home partner would be a woman. So if it feels impossible to have it all, it's because it largely is. Things like banking hours being like the exact same as working hours, like it's really hard in society to be working full-time and parenting or doing some combination of all of those things. So I don't have any, you know, immediate, easy solutions, but I do have a lot of compassion.
Lizzy?
I co-sign everything you just said, Hannah. You know, I think about, it's unfair, and it's like right off the bat, structurally, as Hannah said, it is unfair that in our society that there's an inequitable division of emotional and domestic labor based on gender identity. And while we've made a lot of gains as women over the years, there still is an inequitable division of this labor. And so when push came to shove and the pandemic hit, it is unsurprising that many women were forced to leave the workforce to take on a more prominent role in the home. And it's unfair, and all emotions that come up around that, anger, sadness, disappointment, even some relief, right? Some people, this may have been a welcome relief in some cases, and that's okay too. All emotions are valid around it. I couldn't agree more, Hannah, about self-compassion. I know I've mentioned self-compassion like 3 times already, so if folks aren't sure what that is, I do want to direct folks to Kristen Neff's research of NEFF. She is a wonderful researcher, a psychologist who's based at UT Austin, who's dedicated a lot of her career to research on self-compassion. She talks a lot about the difference between self-compassion and self-esteem. And you can visit her website, selfcompassion.org, where you can take an assessment about your levels of self-compassion. There's also a lot of meditations on that website revolving around self-compassion. She has a wonderful book called the Self-Compassion Workbook that you can purchase as well, that can help in a self-help kind of way, which I know jumps one of the questions. Spoiler alert, that's a great self-help resource. The last thing that I'll say is it's really important to leverage your community where you can, if you are a woman who is experiencing struggling to have it all and the shift in identity. Because that's really what someone might be experiencing. If they were someone who was juggling many things and now is not in the workforce anymore, there really might be a fundamental shift of identity, which can be quite destabilizing to folks. So if there's times that you're needing help, please ask for it. There might be someone in your village, so to speak, who can offer childcare for an afternoon or help to cook a meal or can refer you and provide a recommendation for a job if you're ready to rejoin the workforce. I also want to say that it very well might have gone the other direction. Many women are breadwinners in their home, even though that is the exception, I would say largely in our society, and they may have been the one who had to double down on their work and give up some of their time with their children or their partners at home, and that might be really tough on them as well. So there's many different ways that this can look, but just, again, important to be compassionate with yourself, to validate your emotions, and to ask for help when you need it.
Thank you. Did either of you want to add anything to that? No? We're good? Thank you. Okay. Getting help for mental health issues in these times can take a lot of time. How do you help students, clients, or family and/or families to navigate the process of accessing services? And then I have a follow-up, but let's start with that part. How do you help, given the time it takes to get services these days, how can you help those students or clients or families to do so?
As one of the presenters already said, Psychology Today is a place I refer people to all the time because you can put in your zip code and other parameters and it will give you a whole list of people. But there is a long wait and it's hard. people were having difficulty accessing services before COVID, and now a lot more people are needing services, and so it can be a long wait.
I have actually taken a step. I used to, well, as a school counselor, normally the emails that I send off are to my students, but as this year, really, I have moved towards the emails being directed not only to my students, but to the parents as well. I mean, luckily, Terri and I work in the 11th largest school system in the nation, and they are not devoid of resources. So it's really about getting those resources that Fairfax County Public Schools offers into the parents' hands. And sometimes those resources may be webinars about anxious children or parenting. Fairfax County Public Schools has a parent resource office, and they are consistently and constantly putting out information. So I have really started to make sure that that information is getting into the parents' hands. That's something different I did this year. And then of course, even just through the government, you know, Fairfax County Public Schools or the Fairfax County government, the webinars are free, you know, and if you, even if you just Googled webinars for, you know, parents of anxious children, you know, they will pop up. Mm-hmm.
Lizzy?
Sure. So in most cases, the time that I'll be providing referrals to clients is when it is in two cases. One is, so at Catholic University Counseling Center, we have a 45 session limit, which actually is very, very generous and unusual at college and counseling centers. I would say that kind of across the nation, you know, maybe 4 to 6 sessions is on average. So 45, I feel very, very fortunate to be employed here where I can really do what I consider to be long-term therapy. But there are many students who need more after 45 sessions. So we'll be having a continuous conversation about how many sessions are left and if they are wanting and needing continued support in the community afterwards. And like my colleagues on the panel have mentioned, it can be hard to access services at this time. There can be a wait. So I get the ball rolling as early as possible, usually around 2 months, maybe 6 weeks out if, on the short end, to really start providing referrals. And so I'll have a conversation. So that's the one case. It might be that they're running out of sessions. The second case might be that they're relocating. Most folks who attend Catholic University are not from DC, so they might be going to a state where I'm not licensed, so I can't continue to work with them virtually. And so then I'll be helping them to find support in the community over the summertime or over the winter break, and then they can return to work with me when they are back in the jurisdictions that I'm licensed in. So we'll have a conversation. Yes, psychology today is wonderful, as my colleagues have mentioned. You can search on so many different categories, including insurance and location, if you want to be seen in person or virtually, religious identity of the clinician, the gender of the clinician, the type of therapy that they provide, and the presenting concerns that they have expertise with. So we'll have a conversation about all those different factors, and then I'll read through all of the folks in the database and pick out the top 3 or 4 that I think would be the best fit, and I'll highlight that in an email to the client. But then I'll also provide them with a link so that they can search within that specialized search, so that they have some self-determination too. They can read about who seems like the best fit for them. I also encourage folks to cast a really wide net. There can be a tendency to like really fall in love with a therapist that they read about and only want to reach out to that one therapist. But many therapists, as mentioned, are full at this time. And this is much to my chagrin, I hate this, but many therapists don't respond if they're full. I will never do that. I hate that. I think it takes so much courage to reach out for support that everyone should deserve an email back with referrals in it if you're full or on a waiting list. But that is not the case out there. And so I encourage folks to reach out to many therapists. If that feels hard for them, and for many students it does, it feels overwhelming, I'll either have them sign a release of information so that I can do some of the calls on their behalf, or we'll use some of session time together to make the calls together so that they can see me model how to do it and then slowly jump into the process. I'll also equip them with questions to ask their insurance company. Even if folks want to pay out of pocket, I think it's really, really important to understand what it is that they're going to be paying for. And most folks want to use insurance. And so I encourage folks to call their insurance company and ask, first of all, I'll provide them with traditional CPT codes for individual therapy or intake or couple therapy, whatever it is that they're looking for, and to directly ask the insurance company, what will it cost for these CPT codes? Do I have a deductible, and how much of the deductible has been met? Is there a limit to how many sessions that I can get in a calendar year? Do I need to have a referral from a primary care doctor to access these services? And I'll also encourage them to ask for referrals that are in network, because they might have folks on their radar that aren't on Psychology Today or Therapy Den or the other places that I search, so that they can be building out their list of referrals. Again, I'll also provide a list for them of questions to ask when they reach out to clinicians, like, do they have availability? Do they work with your presenting concern? Do they take your exact kind of insurance? When is their soonest availability? And the times of day that they're generally available, because it might be that they have availability, but it doesn't match the client, and then it's kind of moot at that point. And if they don't have availability, I'll also encourage clients to ask for referrals in the event that they aren't provided to them. So again, they're building a big list of referrals in case they are having some trouble getting connected with someone. And then I'll provide follow-up. Every week I'll be checking in about, have you reached out to folks yet? If not, what are the barriers? How can I provide support to get the ball rolling further? I also like to empower clients, and I think that this can be hard for folks, and so it can be helpful to hear that, you know, if you've been in therapy before, and even if you haven't been in therapy before, it's important to articulate to a therapist the things that you generally like and don't like. I think it's most helpful if you've been in therapy before, and maybe they've worked with me and there's been things that they loved, and maybe there's been times that I've missed the mark, and being able to articulate that to their next therapist can be really helpful, and to normalize for them it's okay to provide feedback to your therapist. And if they hit a point where the therapist is doing something they don't like, it's totally appropriate to provide feedback then too. And of course, to wait a couple of sessions to see if the therapist can adjust. But if they ultimately can't, it's appropriate too to say, this doesn't feel like a good fit. I'd like support finding another therapist. Can you provide referrals at that point?
Okay, Hannah?
Yeah, so first off, coming from having worked in rural North Carolina, where for 5 months, I was like literally the only therapist who took Medicare in a county of 90,000 people, I am very impressed in comparison with the quality of adult mental health services offered by the Alexandria Community Services Board and NOVA CSBs in general, especially the options of therapy groups. So group therapy can feel intimidating, but the wait times are typically much quicker for group therapy than for one-on-one counseling in the USA, and research shows it can be similarly effective. So that's a great community tool right there. And also, kind of similar to what Lizzy was saying, I use the metaphor of therapy for being like shopping for shoes. So try looking at a couple different people. Kind of when you go shopping for shoes, the first fit might be terrible. It might pinch your feet. It might be so big it feels like a clown shoe. But hopefully you're not just going to be like, I'm done with shoes. Shoes don't work. And you go in barefoot for the rest of your life. The same way, you might try a therapist and then be like, oh gosh, I really didn't like this. But keep going. You know, it's a process of trying to find somebody you can work well with. There's also a lot of free online virtual support groups for a variety of issues, ranging from childhood trauma to grief to depression to anxiety to pandemic stuff. So for example, for IORA, I collected a list of 70 different donation-based or zero-cost online groups like that to distribute to my clients. I can actually email that to somebody here if they'd be interested in seeing that, but like there's a lot of good online stuff too. And as for that self-help piece, the 3 evidence-based self-help tools I typically recommend for older adults that could also work for other ages too are as follows. 1, starting a mindfulness practice to help stay in the present moment instead of the anxiety of looking ahead or the regretful thoughts that can come from looking in the rear view mirror of life. Mindfulness doesn't have to be meditation. It works for people of multiple religions. You don't have to be Buddhist or Hindu or any other faith to practice mindfulness. And it can be any practice that grounds us in the present moment, not just deep breathing. So I like the free app called Insight Timer. It contains over 2,000 free guided mindfulness practices, so that's really good. Second, for quote-unquote type A people, I recommend getting rid of to-do lists, especially in the pandemic, where getting some things done is outside of our control. And that can become a way people with depression or anxiety beat themselves up. So what I recommend is what's called a done list, or a good job journal if I'm marketing it to like younger audiences, and writing down everything you successfully do well and accomplish in a day. And that can be something as small as brushing your teeth, smoking fewer cigarettes than the day before. This is one of the most effective interventions I suggest in short-term counseling, since a part of depression is discounting the positive things that you do every day. It can also create a positive feedback loop of doing more activities that make you happy or that help you create a rich and meaningful life. Third, in a similar vein, writing down a few things you're grateful for every day can also be really helpful as well, especially in the pandemic times. So gratitude journaling is indicated as being an effective intervention for depression, not so much so for anxiety, but it is an effective way to manage depression without a therapist. And also, as many as 40% of older adults in particular report feeling lonely, according to many reputable studies by the CDC. Social interaction in and of itself is incredibly healing, as loneliness is a large predictor of depression, anxiety, and other negative outcomes, including mortality. So looking at things like different programs available in the community through the local area agency on aging. So for example, that could be congregate nutrition. Most people aren't aware that the government pays in almost every single district for free areas for older adults to come have lunch for each other, so that's really exciting. And then also looking at things like libraries have a lot of programming for older adults. Not everybody knows that. Recreation center, there's lots of great places to kind of get out and meet other people.
Hannah, you're dealing with, I think, one of the questions that have come up from the audience, where someone asked, are there sources for activities that could be done while limiting risk? How can older adults regain confidence in engaging with others? And I think some of what you just mentioned about these activities and things that are supportive, if you have anything to add to that, this was a follow-up question someone sent in about how to reduce reticence to resuming activities and what's available where the risk perhaps is limited.
I would say things over Zoom or outdoor things are obviously going to be much lower risk than like indoor things with like a million people. I highly recommend book clubs. I think they're a great way to meet new people, and now there's lots of websites that like just collect lists of book clubs in certain states. So if you Google like, book club older adult, like Alexandria, Virginia or something, or like whatever, age demographic you represent, that would be a great one. That's an activity that works well on Zoom. And definitely outdoor activities, so like clubs that involve walking are a really good one too. And there's lots of great free Zoom resources available. The question is more about how are you going to go about and find them? And that might be a time when it would be helpful for you to contact your local community services board, whether it's Alexandria or one of the other parts of Northern Virginia, because they're more likely to have like a pre-made list of resources. The same way at IORA, I made a list of like hundreds of free online activities that people could participate in to socialize. Covia Well Connected program is another great one. They provide free telephone socialization groups. It's not location based, and that's COVIA. They have about 200 to 300 free groups, basically like any interest in the world. Like they have one for slam poetry, one for people who want to talk about bird watching in Florida, like very specific local interest groups to make people.
I'm sorry, are these all virtual? Because the question was also saying for older adults, activities with limiting risk, that part it's got it, but how do you regain the confidence in moving from that to ones where you're emerging in public? It was like,
yeah, so I think definitely looking at kind of going back to that idea of the hierarchy, so making a list of 10 community events, ordering them in a list of which ones you are like most confident about. Like maybe an outdoor event would be something that's a little bit less scary than, or maybe like a quilting bee where only 6 people will be there will then be a little bit less scary than going to the movies in a packed movie theater on the opening night. So I think part of it, and I'm sure other people can provide like some other feedback, is like make a list of what's going to be less concerning to more concerning for you personally, and then don't dive all the way in, just slowly start getting into the pool.
Thank you. Anybody have anything to add to that? No? Okay. And I think I had a follow-up asking about strategies for self-help or community tools while people are waiting for services, but I think all of you mentioned that in the first half of your answer. So the next question is, providing access to mental health services requires the availability of culturally sensitive systems that are able to deliver services to diverse groups of people. And I think we've already addressed a lot of this, but the question was, what ideas do you have or have you seen used to address cultural competency? A lot's already been said, but if any of you have anything to add on that before we move on, or have we covered it all?
For me, it was a personal experience. I had to first acknowledge my own whiteness before I could support a black family. And it is a black family that I'm thinking in my head, and it was a conversation where I felt that I wasn't quite connecting with the mother of my student as well as I could have. So I was not afraid to reach out to, she happens to be our school attendance officer, who is an African American woman, and explained the situation, and she agreed to call this mom on my behalf. And sometimes that's what it takes, that extra step of connecting someone with someone they may be more comfortable with, and me being okay with that. It's not a personal something. So I think that's a possibility too.
Thank you, that's good. Anybody else?
I guess I would just say too is about being open and curious in understanding your own, as was just said, that your own biases, we all have them. And being able to label them and put them out there out front and say, I can't understand your perspective because I am a white female. Please help me, enlighten me, tell me what it's like for you.
That's good. Lizzie, Hannah, anything else, or yes or no?
Well, sure. Well, two things. I really quickly wanted to actually go back to the last question very quickly to talk about some other resources for the community, which are some crisis resources, which I think are very important during the pandemic. So there's, of course, the National Suicide Prevention Lifeline, 24 hours you can call if you or someone that you care about is having active or passive suicidal ideation. There's also the Trevor Project, which has a hotline you can call, an online community forum online. I think there's a text feature as well for LGBTQIA youth. There's also the crisis text line, which I think is really important for young folks and young adults who might feel much more comfortable texting than having a conversation on the phone. Again, this is a 24-hour support line that clinicians run. There's the Steve Fund, which is for BIPOC college students to get support 24 hours a day. There's the Trans Lifeline as well for trans-identified folks who are in crisis. And if you're looking for a support group, I know Hannah mentioned, there's many out there. You can visit Mental Health America's website, which has lists of many support groups that are both virtual and in person. And just to say that there's a lot that we can do, even if it isn't a formal community resource. I once worked for a wonderful organization, and the head of that organization talked a lot about that he grew up on the golden rule, which I also grew up on, this idea that we should treat others like we want to be treated. And he suggested instead the platinum rule, that we treat others how they want to be treated. And of course, the only way that we can know that is if we're asking, right? So if someone is coming to you in distress, to simply ask the question, like, how can I best support you in this moment? you might otherwise launch into what you want, which is maybe advice giving, right? Or a hug. And for them, they really might just want you to hold space and to listen and validate their emotions. So that is a really small community tool that all of us can employ in our daily lives. The other is like simply when you ask someone how they're doing, if they give you a curt or a terse response, just to say, tell me more about that. Help me understand better, so that people feel like they really want to be heard and have more space to express themselves. And then Jean, coming back to the question I know that we're on right now about cultural competence, I love what Hannah said about cultural humility, this idea that really learning about other cultures is not a destination, it's more an ongoing process, and the importance of really asking folks about what facets of their identity are currently contributing to their distress, and really understanding their unique intersecting identities. And I love what was said about we need to ask people what their experiences are like, but we also want to make sure that we're doing that in a careful way, that we're not asking someone to teach us about their culture as an expert, but really making it clear, I want to understand what your unique experiences have been and how this impacts your current mental health or impacts the reason that you're coming to speak with me today. I think it's really important, as was mentioned, that as clinicians or as school counselors, we do our own work about our unconscious bias, that we go to unconscious bias trainings, that we're doing reading, that we're keeping apprised of current events, and know what our stimulus value is in the room, right? Even if I say nothing about my identities, I look a certain way, you can tell that I am a white woman in the room, and people respond to that, and we need to make sure that we're acknowledging that in the room with folks and opening the door for others to feel safe talking to us about their identities by us first naming our own identities. I also think about, the part about being apprised of current events is important because a client can feel very seen if I go in and say to them, I was thinking about you this week because of this facet of your identity and this thing happened in the news. And I want to understand how that impacted you if you want space to talk about it. And sometimes they might say, gosh, no one's asked me about that this week. Thank you for the space. Actually, I really want to talk about my anxiety and not talk about that today, but it feels so good that you asked. Or they might say, yes, thank you for asking. I really, really want to talk about that. And of course, there's 1,000 other answers they might have, but making people feel seen in that way can be very, very validating. And just in terms of the multicultural perspective or cultural competence, whatever we want to call it, it's really, as Hannah beautifully said earlier, it's important for folks to have therapists who share their identities. And a big problem is that historically white women or white men have predominated in the mental health field. And so it's really, really incumbent upon our gatekeepers, which are the universities that admit school counselors and psychologists and social workers into the field, to make sure that they are including having diverse classes basically in cohorts, to make sure that the folks entering and coming into the field represent all kinds of different intersecting identities.
Thank you. Those are all good points. And I'd like to add, just because you mentioned it, Lizzie, and reminded me, we at Bethel on the Inclusion Committee did put together a list of some of the mental health resources that Lizzie mentioned. There are copies here at Bethel that you're welcome to take, and we've put it online if you're not here on the website. Dawn's holding up a copy over there. We've made it to, I've got one more question, but I'll save that till the end. I'd like to take a couple of the follow-up and new questions from the audiences that I've gotten. One goes back to the very beginning, something you said, Randy, I think. You discussed 3 tiers in the schools. I'm familiar with them, but again, it didn't occur to me. Someone wrote, please explain what this means. What tier has more people? And it seems to suggest before or after COVID, how has that affected the tiers?
Very good question. So tier 1 is for all. Tier 2 are for your at risk. You are noticing that they may need more individualized or small group instruction. So 1 is all, 2 is small group, and tier 3 are your high at risk by that point, you're working with school social workers, you're working with the school psychologists, there's family resource meetings happening in the community to support families. So those are your tiers.
Did the tiers exist prior to COVID?
The tiers exist prior to COVID. It is
Yeah.
part of the multi-tiered systems of support that Fairfax County Public Schools models themselves after.
And it's also speaks to academic behavior and wellness. So we're looking at all three of those components on tier 1, tier 2, and tier 3.
And since there was a question as part of it for before and after COVID, did the county change what they did or how they handled those 3 tiers afterwards?
Not too much in terms of academic, although there's funding from the federal government now to help support the academic loss that happened during those years. But there has been a much bigger emphasis on social and emotional learning over the last couple of years.
I definitely see that the tier, and specifically in the last 2 years with COVID, that the tier 2 and the tier 3s have definitely widened. They have grown exponentially, and it's become, recently at our school we have what is called an advisory council, which is a part of the American School Counselor Association process to discuss our programming. And we luckily had one of our school board members present at the meeting, so it was our time to explain that the 2 social workers that we have caseloads of 1,000 students each. So it was, you have to take those times, and yeah, so there's lots of continued conversations in terms of staffing being appropriate.
Well, since you said staffing, there's another question that's directed to you too. And I'm just going to read it. As a healthcare provider, I've always been more concerned for our school teachers as they return to the classroom. Do you provide support to your school staff? Where do you get support for yourself if needed? It's the question about, we're talking about the kids, but you were the people with them and all the things you've gone through, virtual teaching and all.
I don't know how to say this without giving anything away.
Well, as the 2 of you, and I'm looking at my son, the technician, is also a high school teacher, so.
Oh, there you go. I have to say, even, COVID, pre-COVID, teacher self-care was important. And I have been in a multitude of buildings throughout my time in Fairfax County Public Schools. And I can say that it is site specific. It really depends on the thinking top down. What do the principals make important? What does administration? And I have seen the gamut. And it can cause a lot of disruption and movement.
As in teachers going elsewhere.
As in teachers going elsewhere. So I have witnessed that. So it is very different. But we definitely, teachers are, in our student services, having been a teacher myself, I feel like I've tried to get our department student services to encompass teachers and speak to them more if they also need help, they need support, they know that they can come to us as well.
And I would say, staff often reach out to me, but also Fairfax County Public Schools has a pretty good employee assistance program where you have counseling sessions available to you, and I know a number of our staff have used the services and been happy with that.
Lizzy, I know you're working on a campus. You have anything to add to that in terms of staff care, self-help for the staff, or what is provided?
Sure, I can speak a little bit to it. We also have an EAP program, Employee Assistance Program for staff. At the beginning of the pandemic, we actually at the counseling center stepped in a little bit, which is not a traditional role for us to be helping staff members. It just felt really important as clinicians for us to do what we could in terms of helping initially professors move to fully virtual, and also how to support students when they were struggling a little bit more. We had always traditionally helped, and fielded calls and done consultations with professors and other staff about how to support students, but this was more of how do we help them specifically during the pandemic, and how do we also make sure that we're taking care of ourselves as we're helping, since we're all collectively going through this together. Yeah.
Anything to add, Hannah, before I move on?
No, I don't work in a school setting, so
Okay.
I think everybody else has summed it up perfectly.
Okay, great. Okay, we talked a little bit about Zoom fatigue at the very beginning, and someone followed up with a question. Do you recommend blue glasses or blue glass to reduce the glare of a computer screen? Anybody on that?
I know that several of my staff members purchase them and swear by them in terms of helping to reduce headaches from being on screens so much. But that's...
Okay, well, that counts. Michael, did you want to add?
There are also apps that you can add to your device that do the same thing. That way you don't have to have a purchase.
Was everyone able to hear that?
Yes.
Okay. The last question I've got is a little different from the others. How does the political climate factor into recovering from isolation caused by COVID? And the person notes, I found that I'm so concerned by, and I think the word is divisive, the divisive climate, that it's hard to see the light at the end of the tunnel. Any takers? Well, that's a harder one because, again, all are welcome, but if that's affecting someone's ability or reluctance to rejoin in-person activities, have you run into any of this, any of you?
I can't speak too much about solutions or anything. Can you hear me okay?
Yeah, now I can.
Yes.
Okay, perfect. Yeah, so I can't speak too much for solutions, but I can say almost like a little Band-Aid for the situation is try to find places where politics doesn't come up. Like, for example, in my therapy groups, even though, like my COVID isolation therapy group, even though obviously politics was a part of COVID, it wasn't something, I made a group rule that's fairly common in many therapy groups not to discuss politics. So finding places based on a shared interest, so for where like most of the discussion will be about that, or finding volunteering opportunities, even political volunteering opportunities, would be a way to make sure that there isn't going to be that same, divisiveness. But I think it is really hard, so I just want to say I have a lot of, compassion for that because it is so challenging. And I think the group polarization that's coming down the road now, people like, when you open up your Facebook, what you see on Facebook reflects your political values. When you search Google, what you search on Google reflects your political values. We're all, in a way, living in our own little bubble where technology is trying to feed us content it thinks we'll relate to. But in a way, somebody across the political aisle from you, they're getting their own, bubble of content that's like the exact opposite of maybe what you would search for. So I think it's going to be increasingly challenging in modern times, especially with the pandemic ending and people with different political affiliations having different theories about COVID. So no easy solutions, but definitely, it's tough.
Well, go ahead, Brandon.
No, I was just going to say, interestingly enough, this is a positive experience as it relates to politics and schools. I have seen our students as recently as a couple of weeks ago responsibly participate in walkouts based on the topics of the day. So I think that, I know our last question is in terms of positivity, what sort of positive things have I seen? And this, you know, with the political climate as it is, I have definitely seen an uptick in our youth becoming involved and making a very purposeful and meaningful and responsible stance one way or the other. So it's been nice as well.
Great, well, since you led us into that, let me ask the question so that the audience understands. The last question was, what are any positives that we can take away from the last 2 years, even as we're recognizing all of the mental health challenges? Were there good things to come out of it?
I would say one of the good things that came out of it for my anxious friends was not having to come to school. They soared. They just thought they were in heaven. And just was an amazing experience for some of them. I also know that we all gained some new tech skills, learned how to navigate lots of different platforms, and don't ask me about some of them anymore. And then I think one of the things that we did learn is that for most kids, in-person learning is the best thing.
I personally would like to say that I am the best thing that has come out of COVID for me are these conversations. It is much more often that I get to have these conversations in groups. I hear people talking about it when I'm out. I see it in the news. So I feel like there has definitely been a shift to normalizing and mental health, and you see that a lot. With they're also utilizing pop culture, getting Michael Phelps involved. Folks that the kids recognize. So I have definitely see that as a positive move.
Thank you. Lizzy?
Yeah, I love everything that's been said so far. I think something very specific that's come out as a positive is the widespread acceptance of virtual therapy, which makes therapy so much more accessible to folks who, well, in general, but also especially in rural areas. Like you mentioned earlier, Hannah, you were the only gig in town for all of the, for what would you be, 90,000 people, which is wild. But now, it is much more accessible to see someone far away. I think actually folks in rural areas were ahead of us in this way because they were forced to be. But I'll say that, I feel like I was pretty traditionally trained. I was taught how to do therapy in the room, and I'll be honest that when the pandemic hit and I had to scramble to learn how to do virtual therapy on the turn of a dime, I was skeptical about if it was going to be the same and if it was going to be as effective. And I can very confidently say that I was surprised at just how equally effective it is. Yes, it is not the best intervention for certain populations, but I would say that for 99% of people, it is just as effective. And it makes it more accessible in other ways too, in so much as that it takes away a commute time so that people don't have to give up as much time to go to therapy. And it allows people to do therapy in a place that they're comfortable. I remember working with someone for about 1.5 years, and we were culminating our work because she was graduating in spring semester of 2020. And so the last couple of months of our work were done fully virtually, and she would attend sessions in her bed. And it was like talking to a different person. And I shared that with her. I said, I noticed that, since we've been meeting virtually, you seem to be much more engaged and more open in therapy. I wonder if that's been your experience as well. Does that match your experience? And she said, absolutely, that something would happen on her 10-minute walk to the counseling center where she would build up walls. But being able to just sit in her own bed where she was comfortable and have a conversation with me allowed her to be more vulnerable and open. And she made huge progress during that time. She also talked about how there was no transition time. There was no time to get anxious about talking with me because she would go right from whatever she was doing to right popping into a session with me. And as a therapist, I've been able to get so much more collateral information about my clients, typically, traditionally, if they're sitting in a chair across from you that you offer them, right, you don't get to learn about, how they might be comfortable or where they might be comfortable in the room, even if we try to offer as much choice as possible. But in Zoom, or however it is that we're meeting, through a HIPAA compliant video software, right, we can see maybe their bedroom behind them. We might be able to see, hopefully people aren't walking through the space because of confidentiality purposes, but every once in a while you might see someone, right? And then of course, you stop talking to protect confidentiality, but you might not know that that person existed before, and now there's more kind of grist for the mill, so to speak. Also, you get really, really good facial experiences when you're just zoomed into someone, even though you've missed the rest of their body language. You can comment on the things in their background, the places they're choosing to sit. If they're in different settings every time, you can be curious about that. So as someone who really owns their skepticism about the virtual world of therapy, I think that it has done so much for the field, and I'm very, very excited about this shift. I talked a lot earlier about how I see this as a collective trauma, and I think there's a lot of focus on the deleterious impacts of trauma, like PTSD and other adjustment disorders that might come out of it, but there's also post-traumatic growth. For many people, there can be positives that come out of trauma, things like having more appreciation and gratitude for their lives, also more confidence in being able to help people who've gone through a similar situation, or more empathy for those people who have been through similar or difficult situations. They also just might feel much more capable eventually, that they were able to persevere and have resilience and get through something difficult. I also think that for many people, the pandemic allowed some space and time to really assess their values and take stock about the kind of life that they were living. And, we've seen the great resignation happening. I think part of that is, there have been systemic factors that have made it hard for people to work, which is unfortunate. But for many other people, I think that with this workforce for certain industries, people have felt much more empowered, that they can ask for things from their employers, and if they don't need it, that there's many other jobs that they can get. So I think it has fundamentally shifted our workforce in some positive ways, including for some industries having permanent flexible working with hybrid work that has allowed people with chronic illness or disabilities and long COVID, unfortunately, to be able to keep working even if they aren't able to get into the traditional office, so to speak.
Thank you.
Hannah?
So I think this is an amazing question to end on. So there's 3 positives I can think of, and I'm going to try to keep it short because some of them are a little redundant from what other people have said. First off, I think the rise of remote work is going to be great for the environment, and it can be beneficial for people's mental health too. It can promote positive work-life balance by eliminating of commuting time. Although, some people benefit from the office structure, some people benefit from being at home. They get more time with beloved pets. People may have more time during lunch break to prepare healthy food or do housework or things like that. I actually had COVID last week, and I was able to work 5 days. That wouldn't have happened if we were still tied to that in-office structure. I was feeling well enough to work. So it actually helps people be in the office more, whether it's because of a disability or because they're feeling sick. And then the second positive that I can think of is people are starting to consider telehealth more as an option for medical care, and that can democratize the process and improve provider access in rural areas, like Lizzy said. So on average, telemental health outcomes are pretty comparable to in-person outcomes. And some of my patients post-vaccine have even stated their preference for teletherapy forever because it means they don't have to worry about gas prices, so that lowers that economic barrier. They don't have to worry about childcare. That can be a really big thing. So this definitely helps reduce barriers and helps more people get access to therapy or counseling services. And then 3, sometimes I think it can actually bring families closer. So long distance friendships or families where people previously didn't think to use video chats are starting to use video chats. So personally, I get to FaceTime with my baby niece, Gloria, or for my mom and dad's birthday when we're spread throughout different states. My siblings, my parents, and I can all Zoom and kind of see each other when previously, say, I would have called them, and then separately my little sister Allison would have called them, and then my older sister Rebecca would have called them. In a way, it's actually created more space for family time for families who are already geographically apart. So overall, I hope that we can use all these silver linings and propel them forward into a world where hopefully, we get to be in person more.
Thank you, Hannah, that's great. Unless there are any more questions from the audience that weren't passed up, I think that concludes our program. Thank you all for coming today. Special thank you to all 4 of our speakers. And again to our volunteers. Thank you.
Thank you all.
Thank you.
I have